Okay, so this morning I'll talk about stuff I know a little bit more about. Fascinated with the airways, they're good things. So I'll talk a little bit about mask ventilation and challenges and intubation challenges, what we can do to make intubation safer. But I think more and more intubation isn't always the solution, and we need another solution, and I think that's the LMA. And then I'll finish a little bit talking about a LMA surfactant trial that we have running at the moment. Okay, so we'll start in poll mode. So who has used a laryngeal mask in a baby, not in a mannequin? That's excellent, if that's... But it's wonderful to see that the number of people that have used these is growing, essentially. That for a long time used to always be a zero or nearly a zero. Okay, so mask ventilation, it's well known, it's well proven that it's difficult. It's frequently complicated by leak, airway obstruction. That's often not realized or not detected by the resuscitator. We've done lots of studies to see what can we do to make that go away. We've looked at mask size, mask hold, mask shape. It doesn't really matter. A carbon dioxide detector can help in real time to show you that you've got the head position right, but it's tricky, and it doesn't always work. The group from Leiden have shown that the pressure that people put on a face mask is sizable. The average weight pushing down in a small baby's face is that of a pineapple. So you can imagine that's not really what you'd like. And most of the time these days, if a face mask ventilation isn't working, people will reach for an ET tube. But we know that intubation is a difficult skill to learn. Success rates are low, but the current expectation is that most people taking care of newborns are competent intubators. And I mentioned yesterday that I think that expectation is becoming more and more unrealistic. So I guess, well, why is it an issue now? You know, we've been around for a long time. Why is it an issue now? And it's because our practices have changed substantially. You know, I started in neonates a little bit more than 20 years ago. I was in a hospital with 10,000 deliveries a year. I was in a 1 in 5 roster, and we intubated every baby born through meconium stained liquor. So within the first week on the job, I literally probably got 20 intubations. But we don't intubate those babies anymore. The same as back then, you know, the best registrar was the one who could get the ET tube down in the preterm baby's trachea within a minute of it being born and the surfactant in. We don't do that anymore. We stick some CPAP prongs on them now. You know, more and more non-invasive support is used, and those babies that do get intubated, we try and extubate them again very quickly. And then we're also seeing now that surfactant has been given in different ways. And this is all coupled with an ever-increasing number of trainees that is trying to divvy out those number of tubes between them. I showed this yesterday, that the number of intubations per trainee is steadily falling. And unfortunately, what that brings with it is success rates fall as well. Does it matter? You know, as long as you can get the tube in and you get it in eventually, does it matter? And unfortunately, it does. It matters quite a bit. It's well proven that if you can't intubate efficiently, then the resuscitation gets delayed, and hypoxia is prolonged. And the risk of adverse events increases fairly steeply with each attempt. So by the time you get to a third or more attempt, you're talking a 10 times risk of adverse event. We know that tiny babies being intubated in the delivery room, if they have multiple attempts, their risk of IVH goes up and their risk of neurodevelopmental impairment increases. And these are just the adverse events that we know about. You know, it's really difficult with preterm babies to figure out what has caused harm along the way, because the harm is often not visible until many years later. This is not including how many babies have had vocal cord damage or airway or pharyngeal damage or have oral aversions or feeding problems. So this is, again, the Near for Neos group led by Liz Fogley in Philadelphia and NIDIS. They have produced lots of very useful data on intubations in the last number of years. And again, they looked at adverse events, and you know, As you go right, the black box is taking up to 3 or more attempts, and the risk of adverse events becomes significant the more attempts you've got. Okay, so well, how successful are we at getting tubes in? You know, and again, the Near for Neos group published this in 2019, and that was looking at more than 2,500 intubations from 10 academic centres, and they found a first pass success rate of around about 50%. And they showed, which is a very consistent theme, if you go into the delivery room, that success rate gets worse. If you have an inexperienced operator, that success rate gets substantially worse. A few years ago, we looked within 4 units in the UK to see if maybe we're doing it a bit better, and not really. You know, again, we were slightly better overall success rates. Our seniors were slightly better, but the same deal. You know, lots of the time these tubes are not going in. It's taking multiple attempts to do so. We found escalation plans were inconsistent. It was not uncommon at all for someone to just keep trying and, you know, not really have a way of escalating to someone senior very quickly. And what we found very worryingly was that this was a study that we did prospectively over 12 months. We had 122 clinicians and 218 intubations. So, you know, they got a handful each, you know, very, very few. We surveyed trainees right throughout the UK, nearly 650 responses in all different levels of training. Most of them said that they're not getting enough intubation experience. They're not comfortable and competent intubators, but yet a lot of them are going ahead and doing it anyway and supervising others, and that's a very difficult situation. 33% had performed less than 10 intubations. Most had no training. Only a handful really had performed more than 40. And the anesthetic literature would say you need lots to become competent, and it's probably also reasonable that you need quite a few condensed together. So our neonatal training is often in and out of units over many years. There's often gaps in training. It can take a long time to build up enough attempts to get yourself up the proficiency curve. The Near for Neos group again followed another bunch of US fellows as they went through their training program and found to achieve proficiency. There was a median of 18 attempts, but that was anywhere from 8 to 46. And some remained, you know, with suboptimal success rates despite having 50 intubation attempts. So it seems that some people just don't get there at all, really. So far it's all highly depressing. Intubations are increasingly infrequent. The number of novice intubators is steadily growing. Most of them do not think they are competent, but this little girl here on the right, she's my daughter. So she was born, she was 840 grams, she had horrific lung disease and very much needed a tube quickly. And babies like Erin will always be there. These are kids we need to get right. Tubes need to be put in efficiently and quickly and safely by someone who knows what they're doing. So I've spent many years trying to see what we can do to get this better. And I think basically, if you can turn an emergency intubation elective, you'll increase the success rate. So if you use means to just take it out of the delivery room, I think you just should use a video laryngoscope. Anyone who's not, I think you should. And then there's elements of the environment that can be controlled, especially for inexperienced intubators to make their chances of getting the tube in better. And then lastly, Kate Hudson and her group in Melbourne have shown if you leave them on high flow during the intubation attempt, they become more successful. Okay, so well, how can you make an emergency intubation elective? Well, you use adjuncts to buy you time. So LMAs, nasopharyngeal airways, face mask, you know, stabilize babies on CPAP even for a little while, but that means you need good quality CPAP available to you shortly after delivery, not walking around with a neopuff mask on the face. Okay, this is where it all started, video laryngoscopy a few years ago. We did an RCT back when the technology looked a bit different. So this is Patrick, this little baby here, 28 weeks in the middle of the night, getting intubated electively for surfactant before we release it. I put the video laryngoscope next to me, he looked in the mouth, and I was able to see that he was getting the tube in the right place. So the aim of the trial was to determine if intubation success rates of pediatric trainees was superior if their supervisor could share their view on a video laryngoscopy screen and then guide them in real time. So all intubations were performed by junior trainees and supervised by an experienced clinician. And all intubations were performed using the video laryngoscope and then randomized to the screen being covered or not. And surprise, surprise, intubation success rates were substantially higher if the supervisor could see the screen and show them that they were in the right place. If you divided by whether or not pre-medication was given first, so no pre-meds would be the delivery room intubations, again, the success rates in both groups were less in the delivery room, but still favoring the intervention group. If you can give them pre-meds, again, success rates of 72% by people who'd never intubated before. That's as good as you're going to get, I think. Okay, so our trial is now one of 8 included in the most recent Cochrane, and that's now up to 759 intubations, and there's one other trial that has just finished recently from Dublin, and they've all shown effect. Interestingly, the most recent Cochrane update included 5 extra trials that weren't in the previous one. The second last Cochrane had 3 trials in it. They were all neonatal, and the number needed to treat at that stage was 4. The 5 that have been added in are mostly anesthetic trials where the intubators were consultant anesthetists, and they can intubate better, their success rates are better, so the effect has been watered down. We think the effect of this is best with the novice intubator starting out, who has been someone standing next to them pointing out the anatomy. But technology isn't perfect. The scopes are still quite expensive. There's some issue with blade shape and size. Some of them need to have the blades re-cleaned. You have to be set it up. You can lose it. And I don't know, I'll still ask, if you can intubate electively a baby in the NICU with me standing next to you in this piece of kit, when does that mean you should be let loose in the middle of the night with a term asphyxia all by yourself, Okay, so then setting up for success. So there's modifiable environmental factors that impact in particular on junior intubators. DeMeo and his group, I think this is a lovely study, I like it a lot, has shown that if you get it right with the first few, so if the first few experiences are positive, that takes them very well up the learning curve. But also the flip side being, if the first few intubations don't go well, it sets them up for failure in the longer term. So we very much try to get them off to a good start, and seen that time after time. Okay, so we asked trainees who were part of the video laryngoscopy trial, what was good and what was bad, essentially. And the themes were very clear. And people do not like it when the baby gets worse during an attempt. They do not want to think they're killing anybody. They don't like the delivery room. It's too stressful anyway. They don't like when lots of people are watching them, and they don't like the parents being present. And then what did they like? Well, they liked a nice stable baby. They liked the use of pre-medication vocal cords that didn't move. They liked using the video laryngoscope. They liked having someone there who'll support them in a calm and consistent way, and present them with clear guidance. So in Glasgow then, in the last number of years, we've tried to implement all of this into clinical care and take it out of the trial. So we aim to improve our first attempt intubation success rates of our junior and our middle grade trainees by 20% without reducing senior success rates. So I think it's obviously really important to get people trained well, but you need to make sure that our next generation of neonatologists have the skills, because it's absolutely necessary that they're going to get there. So we introduced an intubation package that consisted of a video laryngoscope and then certain factors about the environment that we try and control. So we'll match an intubator with an intubation. If it's a 24-weeker being born and likely to be intubated in the delivery room, that's a senior intubation only. If it's a child with severe BPD who's going to crumble quickly if you give them pre-meds, again, senior tube only. An elective baby who's being intubated to go for surgery, that's a different scenario. So we have an intubation pause where we go through all of the equipment. We actively reassure the intubator that it's their job just to identify the anatomy and put the tube in the right place, and the person who's supervising them is responsible for the care and well-being of the child. We have a clear escalation plan, and I think that's well built into our culture now, and it's by the 3rd attempt, it's the best on the floor. So that, may involve going to get someone from a different part of the floor. That's all good, but nobody is supposed to just keep trying and trying and trying, and that's consultants and everybody. So we did a run chart, because that's what you're supposed to do, and we found that our success rates 40 up to 60 and a bit, and it stayed there. We had one bad month, but by and large it has went in. So pre-implementation, we had a junior success rate of 37% and 3 or more attempts 34% of the time. We've taken our junior success rates up into the 60s and 3 or more attempts consistently lower. So we're happy with that. And we're a busy unit. We have lots of very sick babies. We have lots of airway babies, abnormal anatomy. I'm proud of those success rates. Okay, and then high flow to improve intubation. It's a simple intervention. Babies who've got a high flow on during the event stayed stabler for longer. Lots of the babies that we intubate are on CPAP already. Makes sense to me to just leave the CPAP on as opposed to cracking open a different set. So we use our video scope all the time anyway. So this is what it looks like in our place. Okay, we've found our biggest improvements are in the ones you can control the most. So the elective tubes in the NICU, we do well at them. We're still struggling in the delivery room. Our senior trainee performance is not as good as we would like it in the delivery room. I suspect that's not that they're not getting tubes in, but I suspect that they pull them out if the baby doesn't respond straight away. Their confidence that that tube is in is just not what we would like it to be. And again, if you can intubate in a controlled way, when does that mean you should go by yourself in the middle of the night? That's where I think we need another solution. So the number of intubations per trainee is tiny, and I don't think we're unique with that in the UK. I think that's a worldwide problem. So if you're only going to get, 1 or 2 intubations a year, is it then that you're going to train everybody badly, or should you be condensing that down and actually saying these are the population that we absolutely have to train, we'll give them all of it? Okay, so term baby born by SVD gets unexpectedly stuck on the way out. Apneic at birth, bradycardic, remains so despite the kind of the usual first line maneuvers. So we have a SD4 as a kind of a junior middle grade doctor, will be the senior person on site, the consultant on call from home, but they're 30 minutes away. This person has intubated in the past, but not very often, and it was a while ago now. Do you think it's a reasonable expectation that that person should intubate that baby? So what I love is over time, as I've asked this question, that yes box gets smaller each time. That used to be 100%, and I'm delighted that it's coming down, because I don't think that person should be expected to intubate that baby. They should know what their success rates are like, and if they think they can get the tube down, then fine. But if they can't, then they need to do something else. And this is where I think we need an alternative. We need a device that's effective and safe, straightforward to learn how to use by clinicians with all levels of experience. The ones that are out there, oropharyngeal airway and the laryngeal mask airway. There's only one trial that has looked at oropharyngeal airways. It was done in Melbourne. It's a reasonably small trial, only included preterm babies. They were randomized to an oropharyngeal airway with a mask or else just a mask. And there was no difference in the need for intubation or APGAR scores. And in the oropharyngeal airway group, there was an increase in the level of obstruction. So they're gone now. That's the last we've seen of them. However, laryngeal mask airways, much more encouraging. The evidence base behind them is now, it's substantial. The most recent review includes 6 RCTs in nearly 2,000 babies. And what's consistently shown in all of them is that babies who require resuscitation with positive pressure with LMA is more effective than face mask and will reduce the need for intubation in many, or they can be used as rescue if a face mask doesn't work. Now, at the moment, it's term and late preterm infants, but that'll change. So this is the response to the device. So it's all in the diamond is in the right side of the line. So babies are more likely to respond to an LMA than to a face mask. And I think over time, we will move to them being suggested as first line. Babies who are resuscitated with a laryngeal mask instead of a face mask had a shorter duration of positive pressure and ventilation and a shorter duration of bradycardia. And we can see that. Your pedicap changes color quickly. Okay, less babies went on to be intubated. And again, if you use LMA as rescue, the majority of them will not need to be intubated. Okay, these are now heavily endorsed in all of the resuscitation guidelines. In the UK, the big speak is 2 kilos in 34 weeks, but then the smaller speak is the size is getting smaller. There's a variety of them available on the market. This is the one that we've adopted, the iGel. It's not because there's extensive amounts of RCTs that has compared all of these. Tracy did a mannequin study in Sydney, looking at the various different RCT devices, and the iGel was able to be put in consistently by all levels of staff. You didn't have to inflate the cuff. It had a good seal and could deliver high pressure PPV. This one, the AirQ, has been around for a while, but they now have a smaller size that's licensed for within the smaller population. Now, again, experience of using it is still fairly scant, but it's a watch this space. Okay, and what's been shown consistently in all the trials so far is that people can learn this in a simulated environment and then perform in a real life clinical scenario. Success rates are very, very high, and that's with all levels of clinician. It's not something that, consultants are better at putting in than interns. Adverse events seem really quite incredibly rare. And the people will say, oh, that they're not available for every size of baby, but your term babies, the asphyxia in the middle of the night is the one that frightens me. Most preterm babies will come out and cry, and most preterm babies are born in centralized settings where there's someone there who can deal with them. Okay, so we've been advocating for these in Scotland now for a while. They're stocked in all the hospitals. They are part of teaching and staff induction in all of the hospitals. People are encouraged to use them. We've been using them in our neonatal transport for a while now, and we've transported 4 babies with them as the airway. This was a little guy who was born at 32 weeks with severe Pierre-Robin, small tiny jaw, midline cleft. They phoned us after they'd had 7 intubation attempts saying, we're struggling. And I put the iGel in, and we left it in for the next 12 hours. It worked fine. We had a baby last year who was transferred with one in, again, severe Pierre-Robin, who didn't have any intubation attempts. People saw and recognized difficult airway, went to this straight away. This baby, unfortunately, ended up with PVL. Last year's baby didn't. Okay, at our hospital, we're using them as resuscitation adjuncts in the can't intubate or difficult intubation scenario, and then also to give a conduit to give LMA surfactant. So like I said, they're in all resuscitators, all airway trolleys. It's not just a difficult airway adjunct, it's something that we use on a regular basis. All staff is actively trained, and we're encouraging them to use it. And then we prospectively audited its use for a couple of years when we were starting first, and found 44 babies that they were put into, mostly in the delivery room, but there was a handful in NICU, and there was 1 in the postnatal ward. Most babies were term, but not all. The GA section babies feature very heavily, these ones that will come out and not breathe so well. Most of the time they were put in because of ineffective face mask ventilation that wasn't working, so they went there next. Sometimes just because the baby wasn't waking up, these GA section babies that were there for a while. Sometimes it was because there wasn't an intubator that was present, or that they had tried and unsuccessfully intubated, and there was one baby, a postnatal ward baby, that collapsed and had this as their primary airway. So this graph here is success rates of different levels of clinician. Green is good, red is that it didn't go in. And this here on the right is the intubation study that I showed you a little while ago. Again, red is the ones that didn't go in, green is the ones that did. So you can see success rates consistently higher across the board of LMA insertion as opposed to intubation. These intubations, lots of them will have been elective. These LMAs were all in emergency type settings. So this is something that people can perform well in a high stress situation. Okay, in our babies, most of them got better. Most of the time the LMA was taken back out because the baby was now breathing. Many of them went on to stay with their mum. There was 9 babies that were intubated. This here are the reasons why. They were all properly sick babies, that needed a definitive airway. I don't consider it a failure that they got the intubation as a second line airway as opposed to that they got it first off. Again, turn it into an elective intubation. The setting is more controlled. The right intubator can be present. I think it's absolutely fine to do it this way. I will point out that we've had 1 case of an esophageal perforation in a baby who's had a laryngeal mask in. It was a complicated resuscitation. They had lots of other instrumentation in their airway as well. So it's really hard to know what caused what, but we did note it, and we haven't been seeing influxes of many more since, and we're using lots of them now. But when this happened, we were a bit surprised, and we reached out to other groups who were using LMAs more often to find out if they're seeing any trauma with them, and it doesn't seem to be a high incidence thing, but we'll watch this space. That baby, they did heal and they got better, but it took a little while. Okay, so then we wrote this review again a little while ago and concluded that it was an unreasonable expectation that every pediatric trainee could intubate. We're saying LMAs should be used routinely and their use encouraged, and use them as an emergency airway. And following that, the syllabus in the UK was changed, and intubation is now no longer a junior mandatory competency. Again, I talked a little bit yesterday about, but go into the non-tertiary setting, consultant pediatricians who intubate very infrequently, should they still be expected to intubate? So we surveyed Scotland-wide and had a response rate of 89%. As I pointed out, 40% of Scottish births happen in non-tertiary settings, and I think in the rest of the UK that's representative. We found that around about half thought that they were good intubators, which is good for those half, but what about the other half? And if the baby gets smaller and sicker, confidence drops. So 55% hadn't intubated a microprem in the last 2 years. Most of them had experienced a difficult intubation, but the vast majority still felt that they should be expected to intubate. And like I said, it wasn't because none of them said they should be able to intubate because they can and they have the skill to do so. It was more so it's remote locations, it's a life-saving procedure. We kind of felt that we had to do it, which is concerning. Okay, so the themes looking at the difficult intubation, again, they were quite clear. People saying, oh, we're not able to do it. We couldn't get a view. Weren't sure if the tube was in. It might have been in. There's a big pressure still that, the tubes need to be offered to more junior people so that they can be trained. But then what happens if they can't get it in? It can become quite messy quite quickly. You'll have some babies who have got abnormal airways, Pierre Robin, that kind of thing. What was very obvious is that these are traumatic situations for clinicians, situations people do not want to be in. Okay, and then just for the last few minutes, preterm baby, 1.5 kilos, 32 weeks. He's 4 hours old, he's in 35% oxygen, he's on CPAP, and he's born in a unit that intubates infrequently. What do you reckon? How would people treat this baby? Yeah, so Lisa winning by quite a few. Oh, there's some giving LMA surfactant. Who's that? Where is that, if you don't mind me asking? Yeah, where is that? In Sweden, excellent. 20%, my goodness, that's the highest I've seen. Okay, so LMA surfactant is described in trials for a little while now. There's 7 trials published so far. None of them have compared to Lisa. It's always been to CPAP alone or Ensure. But what has been shown is that it seems to work. In most babies, it seems to work. It's an effective treatment, and in trials now it's going down to 800 grams, and you don't need intubation skills to perform LMA surfactant. This is a baby who was 1.2 kilos. He was 29 and naught, and himself and his twin brother, again, obviously in the middle of the night, were treated with LMA surfactant. We put a pedicap in to ensure placement. We have a neopuff circuit that has a duckbill port, so he's now on iGel PEEP. The CPAP is still in his head, but it's disconnected from the wall. And then we put in a catheter into 17 centimeters, which takes it towards the top of the iGel and give the surfactant in slowly. We aim for the baby to be breathing spontaneously during in. If they become apneic, we'll stimulate them. That comes back out. The CPAP gets reconnected, and that comes back out. Okay, so the first 60 babies we treated, we published as a case series. 10 of the 60 required a second dose of surfactant and were intubated for it. 50 of the 60 got better. And there was a handful of pneumothoraces, and some babies were diagnosed with BPD. So that protocol, we have teamed up with the Melbourne team again and come up with a large RCT, which is recruiting at the moment, which is comparing to Lisa. So I think we're hopefully going to finish by 2026. Okay, so in summary, mask ventilation is challenging. Carbon dioxide detector can help. Intubation success rates of clinicians is far less than ideal. Multiple attempts are harmful and dangerous. Video laryngoscopy can help, as can high flow. I think it's unrealistic to expect universal intubation competency. Laryngeal mask airways, I think, are probably better than the face mask. They're a viable alternative to intubation, easy to use, can get you out of trouble. I would suggest making yourself familiar with it, encouraging junior colleagues to use them, and then we'll watch this space with giving surfactant. Lots of people along the way have contributed to this. Thank them all very much. Thank you very much.